The goal of this video lecture is to review the disorders that are classified in the DSM-5 section on obsessive compulsive and related disorders and discuss the characteristics that distinguish these disorders from one another. Remember that obsessive compulsive and related disorders, or OC spectrum disorders, are disorders that are characterized by obsessive or preoccupied thoughts and or compulsive behaviors. So obsessions are cognitions, they are intrusive and unwanted, they cause distress, and compulsions are behaviors that an individual feels compelled to engage in, either in response to an obsession to address anxiety, or behaviors that an individual feels compelled to perform in a rigid way or by applying a set of rigid rules. So our first OC spectrum disorder is obsessive compulsive disorder. Remember that this is characterized by the presence of obsessions and or compulsions. So while most individuals with OCD experience both obsessive thoughts and compulsive behavior, this is not required for diagnosis. And in addition, these obsessions and compulsions need to either be time-consuming. The DSM suggests that an hour or more per day is considered sufficiently time-consuming to warrant diagnosis, or the symptoms cause significant distress or impairment in functioning. A related disorder is body dysmorphic disorder. Body dysmorphic disorder is similarly characterized by preoccupied and obsessive thoughts and compulsive behaviors, but in the case of body dysmorphic disorder, or BDD, these thoughts and behaviors have a specific focus. So body dysmorphic disorder is characterized by excessive preoccupation with a perceived defect or flaw in physical appearance. And importantly, this perceived defect or flaw is either not observable or may be observable but appears slight to others. So common concerns in body dysmorphic disorder might have to do with perceived defects in the face. So an individual might be concerned about the shape or size of their nose or about perceived acne. People also have concerns about other parts of their bodies, sometimes feet. So excessive preoccupation either with a perceived defect that is not observable to others, or if the individual does have noticeable differences in their body, that the degree to which they perceive a problem to be a defect is inconsistent with how they are perceived by others. In addition, the individual engages in repetitive behaviors or mental acts in response to their appearance concerns. So these can include behaviors like checking behaviors, so repeatedly looking in mirrors or other reflective surfaces to check their appearance. It might be repeated attempts to conceal the perceived physical defect. So they might hold their hand in front of their face, they might wear a lot of makeup, they might only wear particular kinds of clothing, or they may refuse to engage in certain kinds of behaviors or present themselves in certain ways due to concerns about people seeing the perceived defect and trying to hide that defect from other people. The preoccupation needs to cause clinically significant distress or impairment in functioning. Before giving a diagnosis of body dysmorphic disorder, we do want to make sure that these symptoms are not better explained by an eating disorder. So for example, an individual with an eating disorder like anorexia or bulimia might have a preoccupation with their weight or their shape. They might be very concerned with their weight. They might be very concerned about perceptions of body shape or the shape of particular parts of their body, such as their stomach or thighs. So if these body-related concerns are exclusively occurring in the context of an eating disorder, we would give the diagnosis of the eating disorder instead of body dysmorphic disorder. But if the preoccupation is not related to concerns about weight or shape, so for example, if an individual with an eating disorder also has excessive preoccupation with the shape of their nose and engages in compulsive behaviors related to that concern, we might give both diagnoses. So it's important to make sure that the preoccupation that we're seeing in a body dysmorphic disorder is not better explained by a different or a related diagnosis. Another related disorder that is characterized both by preoccupied thoughts and compulsive behaviors in a specific domain is hoarding disorder. So the primary defining characteristic of hoarding disorder is that an individual has persistent difficulties discarding possessions. And this is due to a perceived need to save those items or sometimes to accumulate new items. and also because the person has distress when they are faced with the prospect of discarding items. And because of this, they accumulate a large number of possessions that compromise the intended use of their living spaces. So either their living spaces are cluttered or potentially unusable, or if their living spaces are not cluttered and are usable, it's because other people are intervening. So for example, family members or authority figures have intervened to make sure that even though the person is engaging in hoarding behaviors, that they have a livable home situation. The hoarding also needs to cause significant distress or impairment, which includes an impairment in an ability for the person to maintain a safe environment. One of the key distinctions between hoarding disorder and obsessive compulsive disorder is that unlike OCD, hoarding tends to be egosyntonic. So often individuals with hoarding disorder are not interested in changing their hoarding behaviors. They perceive a strong need to save these items. They don't want to get rid of them. They would like to accumulate more items. And they're not interested in learning how to feel less anxious about getting rid of items. So they may be distressed by the consequences of their hoarding behavior. They may wish that their house was cleaner or that they had a safer living environment. And often there are significant tensions, for example, within families of individuals of people with hoarding disorder who might be very concerned for the safety or well-being of the person engaging in the hoarding behaviors. So those consequences of the hoarding behavior may be distressing, but often the person engaging in the hoarding behavior finds the hoarding and the possessions to be very egosyntonic. So this can be very challenging. There are two additional disorders that are included in this category in the DSM that are primarily characterized by compulsive behaviors without the component of obsessive or preoccupied thoughts. So one of these is trichotillomania, which is also called hair pulling disorder. This is characterized by recurrent pulling of hair resulting in hair loss and repeated attempts to decrease or stop hair pulling that are unsuccessful. In addition, the hair pulling needs to cause distress or impairment. An important distinction between trichotillomania and the other OC spectrum disorders is that typically the initial behavior is egosyntonic. So it's not in response to an obsession or a preoccupied thought, but typically people with trichotillomania report that they have a building urge to pull the hair that is then resolved when they engage in the hair pulling. So the hair pulling is reinforced by this reduction in tension. So they're not responding to any kind of obsession or anxiety when they're pulling the hair. They're responding to this intense urge to pull the hair, and pulling the hair itself is egosyntonic and pleasurable. However, the effects of the trichotillomania, so the hair loss, and this can be very significant hair loss, not just affecting hair on the head, but can also affect hair such as eyelashes and eyebrows and hair on the body, can be very distressing. So that's an important distinction between trichotillomania and the other disorders. Similarly, excoriation or skin picking disorder is characterized by similar compulsive body-focused behaviors that are not in response to a specific obsessive thought or preoccupation. So excoriation disorder is characterized by recurrent skin picking resulting in skin lesions. Similar to trichotillomania, repeated attempts to decrease or stop the skin picking that are unsuccessful, and the skin picking causes distress or impairment. And again, similar to trichotillomania, the skin picking is not in response to anxiety or an obsessive thought, but typically the individual will report that they experience an urge to pick the skin that is then resolved and that there's a sense of pleasure associated with the skin picking itself, even though the consequences, which can include things like physical scarring, are distressing or cause impairment. So to sum up, our OC spectrum disorders that are characterized either by obsessive thoughts or preoccupied thoughts, and or the presence of compulsive behaviors. So these include OCD, which is characterized by obsessions or compulsions that are either time-consuming or cause distress and impairment. We have our body dysmorphic disorder, which is similar in that it's characterized by both obsessive or preoccupied thoughts and by compulsive behaviors, but is specifically focused on a body-related concern. We have hoarding disorder, which is characterized by obsessive thoughts or preoccupation regarding a need to save or accumulate items, and compulsive behaviors related to acquiring items or refusing to get rid of them. Another important distinction between hoarding disorder and OCD is that hoarding disorder tends to be more egocentric and more resistant to treatment. And then we have our last disorders that are primarily characterized by compulsive body-focused behaviors, but an important distinction is that both trichotillomania and excoriation disorder, the urges that lead to the hair pulling or the skin picking are urges, not obsessions or anxiety. The hair pulling and the skin picking are typically initially egocentric and pleasurable, but the person experiences distress or impairment related to the consequences of the hair pulling or the skin picking.